Good day. Thank you very much for joining me. My name is Dr. William Audeh. I am the Chief Medical Officer for Agendia. And it is my pleasure today to discuss with you genomic profiling in early stage breast cancer, taking genomic profiling to the next level by expanding applications to improve outcomes. I will be specifically discussing the clinical utility of the Mammaprint 70 gene assay and the 80 gene blueprint assay in the postoperative as well as the preoperative setting. Most of you are certainly familiar with the Mammaprint 70 gene assay, which we consider to be functional genomic profiling of early stage breast cancer. It does provide, as you know, a risk assessment for the potential for distant metastasis in untreated early stage breast cancer, providing an index identifying a tumor to be at low risk or high risk of metastasis. In addition to this assay, we also have the Blueprint functional molecular subtyping assay, which goes beyond traditional pathology of the immunohistochemistry and fluorescent in situ hybridization classifiers to a genomic classifier made up of 80 genes, which will identify a tumor to be driven by signaling pathways indicating a luminal type, HER2 type, or basal type breast cancer based on 80 genes. And we provide both assays together on any sample in which these are requested in a comprehensive combined output. Now, there are many clinical decisions to be made in the management of early stage estrogen receptor positive breast cancer. Among these, of course, is chemotherapy needed? But there are many decisions beyond this for which genomic information is certainly useful, and that is what I intend to discuss with you today. For example, if chemotherapy is indicated, which regimen may be best? Is neoadjuvant or adjuvant therapy the best approach? And this applies not only to chemotherapy, but neoadjuvant endocrine therapy as well. And if neoadjuvant chemotherapy is administered and a pathologic complete response is not achieved, is additional therapy needed, as has been the case in other subtypes of breast cancer? And finally, what can we say about the duration of endocrine therapy based upon genomic profiling? What I would like to show you is that genomic profiling using the Mammaprint and Blueprint assay can inform all of these decisions. Now, regarding the chemotherapy or no chemotherapy decision, of course, we have data from the prospective randomized MINDAC trial. And as you know, this trial was a large de-escalation trial. Although it is sometimes considered a complex trial, it is actually quite simple. It was designed to answer a very specific question. Can genomic profiling of breast cancers with high-risk clinical and pathologic features allow us to identify women who may safely avoid chemotherapy, even when they have features which would cause clinicians like myself, a medical oncologist, to consider chemotherapy? The MINDAC trial confirmed the clinical utility of the Mammaprint 70 gene assay for identifying genomically low-risk women who could safely avoid chemotherapy. The data from this trial have been published in the New England Journal as of 2016, when 60% of the enrolled patients had at least 5 years of follow-up, and the primary endpoint, the 5-year outcome, was presented at that time. Most recently, of course, at the ASCO virtual meeting in 2020, Dr. Fatima Cardoso presented the long-term follow-up results from the MINDAC trial. At this point, with over 90% of the enrolled patients having at least 5 years of follow-up, with a median follow-up of the population of 8.7 years. And here are the high-level results to remind you of the findings. In the 2020 update of the primary endpoint, in which patients who were clinically high risk but Mammaprint low risk were randomized to receive no chemotherapy, their distant metastasis-free survival at 5 years was 95.1%. an excellent outcome, which was not significantly improved by the addition of chemotherapy. These 2020 findings confirmed the original 2016 data and supported the safety confidence intervals of over 92%. Also presented at this time was the distant metastasis-free survival as a secondary endpoint for both the chemotherapy and no chemotherapy arms in this clinically high-risk Mammaprint low-risk group. And as you can see, chemotherapy in red, no chemotherapy in blue. At 5 years, there was again no significant difference between the two, with a 0.9% difference not meeting any statistical significance. However, with 8 years of follow-up, there did appear to be a small difference between the chemotherapy arm and the no chemotherapy arm of approximately 2.6%. This proved surprising in view of the fact that the Oxford Overview had identified previously from over 100,000 women studied in adjuvant trials that the main benefit of adjuvant chemotherapy, at least in its direct cytotoxic effect, would be to reduce recurrences in the first 5 years. Now, the explanation for this finding is shown here when an age analysis was applied to this same cohort of clinically high risk but Mammaprint low risk patients. In this case, exclusively hormone receptor positive, HER2 negative patients. On the left, you see the analysis of women 50 years and under, and on the right, women over 50. And as you can see, the entire difference between the chemotherapy and no chemotherapy arms was limited to the under 50 group, where at 8 years, there was indeed a 5% difference. Importantly, the separation of these curves did not start until after 4 years. So this is a late effect, discordant from what had been seen in many other adjuvant trials. Also important to point out is that in patients with the same clinical risk parameters and the same Mammaprint low risk profile, but over 50, there was absolutely no benefit of chemotherapy at 8 years. So why is there this age-dependent difference? Well, the analysis of the MINDACT population by age revealed these findings. Nearly 100% of the patients, of course, did receive adjuvant endocrine therapy. And as one might expect, those 50 years and under who did not receive chemotherapy primarily were treated with tamoxifen, 55%. A small proportion, 16%, did receive ovarian function suppression in the endocrine therapy only arm, but a somewhat larger proportion also received ovarian function suppression in the chemotherapy arm. So this alone could not explain the difference. The same age-dependent benefit of chemotherapy was seen, as you may recall, in TAILOR-X, using a different trial design and a different assay. And again, I will reiterate that this is a late effect starting after 4 years, whereas the chemotherapy benefit is assumed to occur in the first 5 years, according to the Oxford Overview analysis. Also important to recall is that the magnitude of this benefit of about 5% is similar to that which had been seen in the SOFT and TEXT trials with ovarian function suppression. And this led Dr. Cardoso to state in her presentation that it is possible that this age-dependent effect is due to chemotherapy-induced ovarian function suppression rather than a direct cytotoxic effect of chemotherapy. The discussant at ASCO, Dr. Antonio Wolf from Johns Hopkins, came to the same conclusion. And in closing, Dr. Cardoso's presentation provided this algorithm for the application of the MINDACT data, in which women who are postmenopausal and clinical high risk, Mammaprint low risk, could safely avoid chemotherapy. Premenopausal women who are clinically high risk and Mammaprint low risk could use these data for shared decision-making to consider the possibility of ovarian function suppression or chemotherapy to obtain that additional 5% of benefit. Now, moving on, of course, to the other questions which we always face in the clinic with women with early stage breast cancer. If chemotherapy is indicated, which regimen may be best? Should we use a neoadjuvant approach versus an adjuvant approach? And if neoadjuvant chemotherapy is given and no PCR is achieved, what further therapy besides endocrine therapy may be indicated? To answer these questions, we may look at the NBreast trial and data from the I-SPY consortium in the United States. The NBreast trial used the Blueprint 80 gene assay, which I mentioned previously. It is in fact a functional assessment of genomic pathways, and shown here are the 3 subtypes which are identified by Blueprint. I will call your attention to the large number of genes in the luminal type signature, 58 genes required to identify a luminal or hormonally driven cancer. Now, the ESR1 gene, the estrogen receptor gene, is of course in this group, but if that gene by itself were sufficient, we would not have required an additional 57 genes to accurately identify a luminal tumor as opposed to a HER2 type or basal type. Incidentally, the genes highlighted in yellow and shown in the green box at the bottom of your slide are the 4 genes which overlap with Mammaprint. All others are unique to Blueprint. Now, focusing on the luminal pathway, it is useful to remember that there are 4 methods in use to measure estrogen receptor signaling. There is, of course, the traditional method that we have used for decades and continue to use, which is to measure the level of the estrogen receptor protein. There are assays which rely heavily on the level of the estrogen receptor mRNA to generate their output. But as I will show you, that single gene assessment is inadequate to identify luminally driven tumors. There is also interest, of course, in mutations within the DNA gene and the ER gene itself at the level of DNA, but this has primarily been useful in recurrent or metastatic disease as a mechanism of resistance. Most importantly, and the basis of the Blueprint luminal profile, is that one really would like to know which genes are turned on and off by the functional estrogen receptor, because that, in fact, is the proof that the pathway is active. One wants to see, in fact, the clinically relevant function, and that is indeed what Blueprint provides. Now, the utility of Blueprint combined with Mammaprint was analyzed in a large neoadjuvant study known as NBreast, in which patients were treated with neoadjuvant therapy according to standard of care regimens based upon their initial immunohistochemistry and fluorescent in situ hybridization classifier. Over 1,000 patients were enrolled into this trial. In addition to the IHC and FISH, of course, molecular subtyping with Blueprint was added. And this was, of course, provided on core biopsy by Blueprint. When a comparison was made between the Blueprint assessment and the IHC FISH assessment, it was found that Blueprint reclassified 22% of these tumors into different subtypes. Now, the endpoint of this trial was to look at pathologic complete response. And that was most relevant, in fact, for finding a group of patients that were estrogen receptor positive by IHC, but basal type by Blueprint at the genomic level. Importantly, they responded to chemotherapy much like ER-negative breast cancers and quite differently from other ER-positive breast cancers. I will show you the clinical relevance of this in a moment. But to remind you again, over 1,000 patients were enrolled in this trial. Nearly 700 were estrogen receptor positive, and of these, 91 or 13% were reclassified by Blueprint as being ER positive but genomically basal rather than luminal breast cancers. Their response to chemotherapy was identical to that of a triple negative breast cancer or an ER negative basal. Importantly, in follow-up, the recurrences of these ER-positive basal cancers occurred within 4 years, unlike the late recurrences we expect in ER-positive luminal cancers. And the pattern of recurrence was much more typical of triple-negative or basal-type breast cancers in that at least half were in visceral sites. The molecular basis of this ER-positive basal breast cancer was also described in this important publication in 2019. Now here's the clinical output from the NBreast trial. What you are seeing is all ER-positive, HER2-negative patients treated with neoadjuvant chemotherapy with a pathologic complete response rate of 10% when classified by IHC. Now, when the Blueprint genomic subtyping was applied in combination with Mammaprint, it was possible to distinguish a group of patients that were Mammaprint high risk and genomically luminal, which were called luminal B, with a PCR rate of only 5.6%, and a further group, Mammaprint low risk and genomically luminal, 2% pathologic complete response rate, in contradistinction to what was seen in this subgroup with a 34% pathologic complete response rate to neoadjuvant chemotherapy, even though they were estrogen receptor positive, because Blueprint identified them to be genomically basal. And these, of course, were Mammaprint high-risk patients within the ER-positive subset. That constituted 13% of this total group of ER-positive patients. Now, this entity, ER-positive basal breast cancer, had been identified previously, and the molecular basis for it had been described in this paper in 2013. Importantly, it was found by studying such patients that while they were estrogen receptor positive with significant expression of estrogen receptor protein, they were genomically basal. In fact, the estrogen receptor, although present, was non-functional and not signaling, despite the presence not only of the protein, but also, importantly, of high levels at times of the estrogen receptor mRNA, suggesting that assays which are heavily dependent on that single gene mRNA may be misled by such tumors. In fact, the basis was not a DNA mutation, but actually a variant in the method in which the mRNA was actually spliced to ultimately be translated into protein. It is an mRNA splice variant which produces the ER-positive basal breast cancer. And mRNA splice variants have now been identified in many other malignancies and is an important source of genomic diversity in cancer. Now, one may expect that these ER-positive basal breast cancers identified by Blueprint will be those which have low estrogen receptor expression, but that in fact is not the case. Shown here is the range of estrogen receptor protein expression in these ER-positive basal cancers by IHC. And as you can see, although they do cluster in the lower range of estrogen receptor expression, the range extends from 1% all the way to 99%. In other words, any level of estrogen receptor expression may still be an ER-positive basal breast cancer. The progesterone receptor expression was somewhat more informative, in that there were very few, if any, above 50%, but even a positive PR tumor may still be ER-positive basal. Shown on the right are the PCR rates with the IHC-defined triple-negative breast cancers in the yellow bar and the ER-positive basal breast cancers in the blue bar, showing that these patients behave almost identically to triple-negative breast cancers and very different from the other ER-positive breast cancers that are identified as genomically luminal. Now, what is the clinical relevance of this? When one sees PCR rates of 34% and compared to triple-negative breast cancer? Well, although this made up 13% of all ER-positive breast cancers in this NBreast trial, the I-SPY trial showed an even higher percentage of ER-positive basals, because, as you may be aware, the I-SPY trial uses Mammaprint to screen patients for enrollment. They will only enroll hormone receptor positive breast cancers that are high risk by Mammaprint. So within that subset of all high-risk ER-positive Mammaprint patients enrolled in the I-SPY trial, 29% were ER-positive basal. We may ask then, what are the clinical implications of finding such a tumor? Since the data suggest from NBreast and I-SPY that they are clinically equivalent to triple-negative breast cancer or ER-negative basal breast cancers. Well, here are questions that may be asked. Should different chemotherapy be used? Because many oncologists will select a different regimen for a triple-negative breast cancer versus a luminal breast cancer. Many will prefer to use dose-dense or standard ACT third-generation regimens for triple-negative breast cancers, while many oncologists will choose to use two-drug regimens, such as TC, for luminal cancers. And then, of course, there is the unanswered question as to when to use carboplatin, particularly in triple negatives, and it is reasonable to consider this in a basal breast cancer. We also understand that neoadjuvant therapy is often considered the standard of care for triple-negative breast cancer. We understand that there may be a poor outcome if chemotherapy is delayed, particularly in triple-negative breast cancers, and this may apply to basal breast cancers as well. We also know that the achievement of a PCR in triple-negative breast cancer is highly correlated with long-term outcome. And we did see high PCR rates in ER-positive basal cancers. This raises the further question, in the case of a lack of PCR, we know in triple-negative breast cancers there is a benefit to additional chemotherapy, such as capecitabine, as shown in the CREATE-X trial. Should that be considered for a basal breast cancer, whether it is ER-positive or ER-negative, identified by Blueprint? Now, finally, I will touch upon another question beyond chemotherapy, and that is the duration of endocrine therapy. What can we learn from genomic profiling regarding this question? And for that, we also have data from the STO trial and most recently from the IKA trial. Here I show you data from the STO trial published in 2017 by Dr. Laura Esserman from UC San Francisco and her colleagues in Sweden. This was relevant to what has been described as an ultra-low-risk Mammaprint index. Within the low-risk index in Mammaprint, we identify a section of low risk which is ultra-low. And this was studied by looking at the STO cohort, which I will review in just a moment. Now that study of these patients was initiated because it had been observed that within the low risk index, which by Mammaprint is from 0 to +1, there is a section with extra or ultra low outcomes and excellent prognosis for a Mammaprint index above 0.355. This was validated by looking at the Stockholm tamoxifen trial, a trial in which over 650 postmenopausal women with clinically low-risk tumors up to 3 centimeters and node negative were studied. In that trial, over half were randomized to no endocrine therapy after surgery, while the other half were randomized to either 2 or 5 years of tamoxifen. The blocks from these patients were available, and Mammaprint was run on these blocks. RNA was extracted effectively, and it was found that of this cohort, 19% were in the ultra-low range. Importantly, this trial had over 20 years of follow-up available, so the outcome of these ultra-low risk patients could be identified. And the important finding was that at 20 years of follow-up with Mammaprint ultra-low patients, there was a 97% breast cancer specific survival at 20 years if any tamoxifen had been given, either 2 to 5 years, with 100% breast cancer specific survival at 10 years. Even those who were untreated had a 94% breast cancer specific survival at 20 years and 100% at 10 years. Now here's a graphic representation of those findings. The ultra low risk patients, untreated in the dotted line, treated in the dotted line, and you see their excellent outcome with little or no endocrine therapy. I show you here in purple the low-risk mammaprint patients who were not in the ultra-low range. Although they also do extremely well, they did show a much more significant benefit to the addition of endocrine therapy. Now, what is the implication of this clinically? Well, we now know that if a tumor falls into the ultra-low risk range, regardless of clinical risk, that there is an excellent long-term survival with minimal endocrine therapy. We also know that if a patient is low risk and certainly not in need of chemotherapy, but not ultra low, there will be a significant endocrine therapy benefit. As of now, these data primarily apply to postmenopausal lymph node negative women. We have additional data now presented at ESMO this year in a poster by Oudeh and colleagues from the IKA trial, which further validates the ultra-low risk, showing an excellent outcome from that long-term cohort as well in lymph node negative postmenopausal women. In that case, treated with either no therapy or 3 years or less of tamoxifen. It is important to point out that the SDO trial involved palpable clinically detected patients, while in more modern screen-detected populations, as many as 25% may be ultra-low. The utility here is for women with severe side effects from endocrine therapy who may be allowed to stop therapy early. And they are encouraged, of course, to continue if they're low but not ultra-low. So combining all of this, I want to reiterate that these data, this genomic profiling is available on the samples taken from core needle biopsies. Both the NBreast and I-SPY trial relied entirely on core needle biopsy samples for their genomic assessment. And having these data preoperatively can help to better define and design appropriate therapy plans for your patients with both Mammaprint and Blueprint. Specifically, one could consider an algorithm where for luminal A patients who are ultra low or low risk, neoadjuvant endocrine therapy may be considered, particularly in these days of COVID, to delay surgery or to proceed directly to surgery. This is in contrast to finding a tumor to be Mammaprint high risk and luminal B, or most importantly, Mammaprint high risk ER positive and basal, in which a very different approach may be indicated with neoadjuvant chemotherapy, even for tumors T1C and node negative, where there is a very high likelihood of PCR, much higher than for luminal B patients. So in summary, what I have just described is comprehensive genomic profiling in early stage breast cancer that is available on a preoperative core biopsy or resection specimen. It informs many important decision points in early stage breast cancer, and the results with these assays from Agendia's lab are available within 5 to 10 days on a preoperative core biopsy. We are going beyond, of course, the chemotherapy or no chemotherapy question with this information, giving genomic answers for other clinically relevant questions. Neoadjuvant versus adjuvant therapy, neoadjuvant endocrine therapy or neoadjuvant chemotherapy, and choice of drugs, particularly if one is able to identify that ER positive basal subset, and identifying ultra low patients as well. Both of these findings are relevant for both clinically low and clinically high risk patients. So thank you for your attention. What I believe I have shown you is that the 70 gene Mammaprint and 80 gene Blueprint assay provide the most comprehensive genomic profiling in early stage breast cancer. Thank you very much for your attention.